The following is a production of Different Brains. Visit us at differentbrains.org.
The following Different Brains content was funded in part by the Community Foundation of Broward and support from people like you. In this episode of Exploring Different Brains,
over 70% of autistic individuals have one mental health condition, and over 40% have two or more conditions. And this is starting, there's been some recent research that shows even our children that are like as young as 10 are already experiencing co-occurring. And many years ago, we weren't able to diagnose some of the mental health conditions if there was an autism diagnosis, and now we know better. So we need to do better. It's very difficult sometimes to pick up the mental health challenges because it can look so different. It can look like an increase in autism challenges instead of like a red flag that we're more, might be more aware of that is mental health. And it can look like a traditional, like what we're trained to know as mental health. So it gets a little tricky.
Hi there, I'm Dr. Hackey Reitman. Welcome to another episode of Exploring Different Brains. And I'm very excited today because today we're giving you two for the price of one. We have Christopher Kay and Cheryl Checkers, who are both people that specialize in the overlap of autism and mental health issues. Welcome, guys.
Hello.
Hi, Dr. Reitman. Thanks so much for having us here today.
Well, thank you for being here and thanks for all you do. Please introduce yourselves more properly than I did. So we'll start with Cheryl.
Okay. My name's Cheryl Checkers. I'm a licensed mental health counselor in private practice where I specialize in working with adolescents and adults with neurodiversity and co-occurring mental health conditions. And I'm lucky to be the president of NAMI Palm Beach County. And I'm also a clinical consultant for FAU Center for Autism and Related Disabilities.
And what do you do in your spare time? That's a lot. Dr. K, it's your turn.
Thank you for inviting. I'm a child psychiatrist. I'm in solo practice. I've been doing it a long time. And the clinical focus is actually in autism. And then the training is a little bit different. I did have exposure to neural circuitry in monkey and man postmortem in a lab for a few years. And so it's a little bit of a different point of view, which I feel does inform the practice.
What would you say, Cheryl, is the most common mental health diagnosis in the autism community that overlaps?
Well, that's a really good question. I would have to say anxiety, and I don't know if Dr. K is going to agree, but we work closely together, and I wanted to mention we've known each other for over 20 years, so have a lot of shared patients, and a lot of the people that we see have autism and anxiety and depression oftentimes. So, but I would think that co-occurring anxiety is probably the most prevalent that I see.
Well, I would further extrapolate that to say I think most people have some degree of anxiety and depression.
Well, I'd like to speak to that, and I think that for any of the diagnoses, just to normalize and particularly using anxiety, it's when it crosses or crosses the line or is extreme and it limits what someone can do in their life when we consider it like an anxiety disorder. So yes, it's very normal. We all do experience anxiety, but many of the people that we see are experiencing such heightened anxiety. They're either isolating at home or it's kept them from going to college or cause them to leave college, or it might just keep them from doing the things they want to do, even socializing. So we see a lot of people with social anxiety as well. And, it is normal to have anxiety, certainly, but when it's limiting, life limiting, then that's when we usually see someone.
Great distinction to point out. Let's go to another extreme in some of the population you see that's unfortunately increasing in incidence is suicide. Can you speak to that in this population?
I
Cheryl?
can speak to that a little bit. So, um, I've done, I've read a lot of the research and have been, involved in some projects on the FAU card side, where one of the projects I worked on was creating a training, co-creating it with Dr. Jack Scott, Executive Director of FAU Card, and Director at the time, Mary Ellen Quinn Lunny, on helping educators and different school staff recognize the increased rate of suicide among students, autistic students in the Palm Beach County School District. So we know that for individuals with autism, suicide rates are anywhere between 6 and 12 times higher. So it is, something we all need to be paying attention to. Um, Dr. Kay and I oftentimes work with clients who have what we see as like treatment resistant depression, where they oftentimes have chronic suicidality. So it is something that we see a lot, but also the research is recognizing a lot, and FAU CARD is really, that's one of their focuses, is to increase awareness and to help us all understand how suicidality can look a little different in neurodivergent individuals.
What are some of the challenges when you see someone having mental health struggles? What are some of the problems in assessing where they are on the spectrum, if there is that overlap? Because many times they're not, people are diagnosed later, particularly in the female population, with autism, as opposed to mental health issues, which many times come earlier. And if you could speak to that, and if you agree with that premise.
And that's an excellent question. And we absolutely see people that come to us with mental health conditions that they had sought out treatment in the past, and medication didn't work and therapies didn't work. And it is usually our female clients, and we're diagnosing autism. And that's why, like, the typical protocol for mental health oftentimes doesn't work. So and then they kind of find their way to us as specialists in autism, and then oftentimes they get the autism diagnosis after the mental health conditions, and a lot of misdiagnoses as well. And especially our females, we just, as clinicians, I feel like we just don't do a good job picking up our females oftentimes, and they mask and they hide from us, and they're like little psychologists. They can study what they're supposed to do, and they learn what to do, and so they can look so much different. And it's so important that we're whether we're on the if we're on the mental health side, even if we're not autism specialists, to have autism on our radar, with our females as well. Like just at least even have it on our radar, because oftentimes they're getting borderline personality disorder, and all kinds of laundry lists of different diagnoses, and the autism's being missed.
Wow. Chris, would you agree with that?
Yeah, very much so. So one interesting thing is that, the neuropsychiatric origins of autism, the pathogenesis, where it comes from, it's very early in brain development. So the data is pointing to the fact that it's when you're starting to make your outer circuit board, your cerebral cortex. So during second trimester, and significant maturational changes are still happening, like early after birth, early postnatal. when you're looking at diagnosis of co-occurring psychiatric conditions, or if you're looking at stuff like interventions, so in my line of work, psychopharmacologically, there's, consistent with psychiatric presentations in general, there's a massive increase when you go through start puberty. There's increased reactivity in emotional brain, and vulnerabilities and command control function, frontal lobe, become more manifest. So because the pathogenesis for autism is so early, and because it affects distributed aspects of the neural network, it's not surprising that the pathophysiology, or the mechanism for expressing symptoms for different disorders, is not surprising that it could express in many, many different ways, because it's affecting aspects of neural circuitry that are implicated across different conditions. So the construct of a quote unquote co-occurring condition, which is how we look at things right now in our current diagnostic system, the DSM, you could reframe it from a different perspective and think that, well, with autism, because it starts so early and because it affects a very fundamental part of circuitry that affects all other aspects of circuitry, essentially, that mediate psych symptoms, it's not surprising then that it could express in so many different ways. And, it's not surprising then to look at the diagnosis of autism oftentimes in a population which has less clear, ostensible autism features. So let's say a higher functioning female population, where it looks like that their overall level of emotional and social intelligence overall is a bit higher than people on male. So that's the male brain hypothesis, the Baron-Cohen. It's not surprising then that there would be a little bit of a delay, or more of a delay, in picking stuff up and a misconstruing of things, because currently we still are allowed to diagnose comorbid co-occurring conditions in DSM. With the autism, where when you think about it, because of it from a pathogenesis point of view, you could look at subsequent psychiatric diagnoses in autism as really being secondary phenomena and not primary phenomena, things to be expected as opposed to a surprise.
Cheryl, would you agree with that?
Absolutely. Dr. K, I've been lucky enough to be mentored by Dr. K for many, many years, and learning the neuroscience and understanding it, and certainly not understanding it at the level he does, but understanding the brain differences and why things express the different ways they do, and all those things are so helpful, and even to pass along to the people that we work with, because when they understand what's going on in their brain, it's much easier for them to not feel like it's a weakness, a character, or like if it's anxiety, what's happening in my amygdala, like, oh, it's my amygdala. My amygdala is reacting differently. It's just a really cool thing when you can understand some of the brain science behind it.
I just want to mention, of course, that it goes both ways. So obviously, I have a skewed skill set, and Cheryl's skills compensate for my relative lack of skills. So Cheryl has mentored me through our quarter century of working together. So it's really, I feel so lucky to have been working with her for so long, and that I got so lucky getting a chance to work with someone like Cheryl for so long, because I would say she's a true believer. She's really committed to knowledge for knowledge's sake, to make the world a better place in the world of autism. And she's always been aggressive and ruthless about trying to figure out what information was the most useful and applying it. And obviously we come from different backgrounds, and obviously, what we focus on, it's from a different perspective, even though we're still focusing on the same target. But, it's just been nice working with her through my career, because I really do feel like whenever I've had a challenging presentation, I've always had a better outcome when Cheryl's been involved.
The two of you together are really some kind of dynamic duo. And I think it's just great, all the great stuff you're doing together and individually. What advice would you both have for an autistic person who is having trouble finding a mental health provider that understands autism?
Cheryl, that's you.
Another very good question. So, well, the one thing I suggest is, it is very important to have someone that understands autism, and knowing that we didn't all have it in our graduate programs, especially, when you brought up females, like what female, phenotype looks like versus male. And, so many different things that we don't have unless we train ourselves after, like post grad. So that said, like there are a limited number of us. So I understand, like, it doesn't mean that someone that isn't a specialist can't do really good, working with someone. Um, the card centers are located throughout Florida. They usually have a list of providers that do at least know autism enough, because to get on the provider list, you pretty much have to prove that you've worked with other individuals with autism. So that's I I would recommend that if they can't see and someone that does understand autism, that would be the way to go. But therapy is important. So if they don't find someone that's a specialist, oftentimes, like especially my females, I see a lot of female clients. They know a lot. Like they're very impressive, and my males too. They've already done the research. They oftentimes, when they come to see me, and if they don't have a diagnosis, they're not surprised because they've already taken self-assessments, and oftentimes they can kind of lead a therapist a little bit and help them to learn if it's not a specialist. But I'm definitely taking advantage of psychology today. You can search autism or Asperger's syndrome. I think they still have on there as well, but there are some different ways to find someone that specializes.
How can our audience learn more about you guys?
Dr. K and I oftentimes do presentations out in the community, and as our way of kind of giving back what we know. And we both are frequent presenters for FAU Card. If you want to watch any of my presentations that I've done in the past, FAU Card has a YouTube channel. A lot of them are there. I serve on a lot of committees, and one of the committees I'm on is it's a interagency committee with different card centers and different autism experts, where we're creating trainings so for clinicians and parents and females, so that we can raise awareness, and we can provide tools, and we can get that, like, females on the radar of other clinicians. So a lot of those trainings I've done that are female focused are on that YouTube channel if anyone's interested. I lead a professional task force for FAU Card. It's an ASD and mental health task force with the goal of training professionals, the mental health professionals in autism, and autism professionals in mental health. So it's a monthly meeting, and it's virtual, and we have over 400 professionals from across Florida. So anyone that's interested in joining that's a professional, I highly recommend it.
The websites to go to.
That you can FAU Card again. So it's called the ASD and Mental Health Task Force. So if someone contacts FAU Card, just let them know that's what they're interested in joining. And we have free CEUs every month, and we have experts come out and we have them train us.
You guys have your own websites too?
Yes. It's my first name, Christopher, and then my last name, KYE, MD.com.
And Cheryl, do you have one?
I do. It's CherylCheckers.com. So it is my name, CHERYL, checkers like the game, .com.
What is the one thing that most people don't realize about the overlap of autism with mental health challenges? Cheryl, could you go first?
Sure. I think most people are not aware that over 70% of autistic individuals have one mental health condition, and over 40% have two or more conditions. And this is starting, there's been some recent research that shows even our children that are like as young as 10 are already experiencing co-occurring. And many years ago, we weren't able to diagnose some of the mental health conditions if there was an autism diagnosis, and now we know better. So we need to do better. It's very difficult sometimes to pick up the mental health challenges because it can look so different. It can look like an increase in autism challenges instead of like a red flag that we're more, might be more aware of. That is mental health. And it can look like a traditional, like what we're trained to know as mental health. So it gets a little tricky, but I always like to mention that like anytime there's a big change in baseline, that's when we need to be paying attention and just making sure there's not something more going on.
Chris, would you like to add anything to that?
I'd love to. Thank you. So, it's interesting when you diagnose autism. So we've been using this triad or more dyad of social communication impairment, restricted repetitive behavior, and now we've got on other stuff like, the excitation, the hyperexcitability, decreased sensory gaining. But if you look at what you deal with clinically, one really common thing is a real challenge in handling stress. So under stress conditions, having regression in function, both in the circuitry that mediates habit learning, so a negative cognitive looping or impulsively and compulsively acting out, and also within the emotional system, the limbic system, so at a lower temperature level of stress, anxiety, and at a higher level of irritability. But just because of the way the wiring is in autism, there's a lot more vulnerability to this construct, which is referred to as hot cognition difficulties, problem solving under stress condition, versus cool cognition, problem solving under non-stress condition. And it's something that is intrinsic to the autism presentation and is often interpreted in certain ways in DSM that can be a bit obscuring or confusing sometimes when you look at it more from a neurocircuitry perspective.
Can you talk about the importance of a place like NAMI, knowing about autism, and a place like FAU CARD, being aware of mental health challenges?
Because I've been involved with both organizations for such a very long time in Palm Beach County, I've been able to bring the two organizations together. So, as I mentioned, the professional task force that FAU CARD has and that I lead, NAMI is represented on that task force. And NAMI has, like they said, the mental health side does get a lot of individuals with later diagnoses that have mental health conditions and autism. So they have support groups for young adults and for, they don't have children's support groups, but they have young adults and older. So oftentimes we do have families and their adult children that end up on the NAMI side. It's nice, I think, like we're stronger together, and when you have the support from each side, it's most helpful. So I'm always recommending that all my clients connect with CARD centers, whether it's FAU CARD or UMNSU, wherever they're located, but also that they're reaching out to the NAMI side, because there is a lot on that other side that can be very supportive. And really, it's about connecting and feeling like you're not alone. And oftentimes, especially our young adults, they're getting a late diagnosis, and then you have mental health conditions too. It's very isolating, and just connecting with a group of peers and that really get it is so helpful. So whether it's on the CARD side or the NAMI side, or both of those sides, it can really make a difference as an adjunct to the therapy and other resources. And it really is about building a team and making sure that all those resources are in place, because it's not just one of us that can do it all.
Can you both give some advice for an autistic individual who is afraid to see a mental health provider?
So, I oftentimes work with parents and families where their child is not quite yet on board with going to a therapist, and it might, you know, it might be a young adult, or it might be a child, it might be an old, a middle-aged adult, whatever age, that can be a tough thing to reach out for therapy. And I always think, like, so you don't want to force someone into therapy, of course, just being there to listen and understand like what's going on, if you're the parent or the friend, or even a work colleague, you notice something's going on, like, just being that person that could be there to listen, I think is a good start. And oftentimes you can, like, people that have benefited from therapy can maybe talk to the individual. There's also options of groups. So sometimes one-on-one therapy can sound kind of scary. Like, would they do better in a group at first? Or, so finding, I guess, that whatever's going to work for that individual. And I often call it the side door, so not forcing into therapy, but where can we start? What's a good start? And then try to work towards therapy. I think, making it less scary, understanding what the fear is to begin with, and the fit of the therapist is so important too. But most therapists offer a free consult. So it could be, why don't we just talk to the therapist and just see what you think, even if it's on the phone first. So, that there's different ways to go about it, but it's not unusual for me to hear like someone needs therapy, but they're not open to receiving it at that point. And the same with psychiatry, with medication. I hear that a lot from my clients too. And if they do accept therapy and I'm working with them and I know that they could benefit from having a med assessment, then again, we're going in the side door. Like, what are your fears? And, what if you just go and have one appointment and just listen, and knowledge is a good thing. And then you can make a better decision. So it really is like kind of meeting that person where they are and walking with them through the process.
From my perspective, a common perspective is that it helps a lot to have psychoeducation to let people know the frame of what they're looking at. So, with autism, it's very genetically driven. So the heritability index is arguably number one or number two, but it's certainly about, 4 out of 5 expression, 4/5 is genetically driven. So beyond the genetics, so it's heritable. It's also that it's a brain-based disorder. It's a neural circuitry disorder. And the other aspect of it is that it's a developmental disorder. It starts early, but there's also developmental windows for intervention. There are times where it's easier to have a higher juice to squeeze ratio for intervention when there is still plasticity, like plasticity windows and control circuits. And the other thing is that we're getting a better understanding of what the circuitry is that mediates these symptoms. And I think just giving people information about the brain-based nature of autism, and that there are things that we can do that'll improve function, that help interventions that Cheryl does to work better, that they work complementarily, and they can help in take advantage of strengths, not just address weaknesses. I think this is something that can be very expanding for how people look at the role of intervention.
Well, then to piggyback upon that, where would you like to see autism research be in 5 years? If you can look 5 years ahead.
Obviously one of the real problems that we're having right now in autism research is that we're still searching for a sense of the pathophysiology. So we have all this new data coming out with powerful techniques like molecular genetics and neuroimaging, but the confounds of, is it a causal finding? Is it a consequence finding? Is it a compensation finding? Is it something that reflects a comorbid condition? Is it something that reflects a compound of experimental design? Until we have a better sense of what the underlying pathophysiology of the neural circuitry is, it's kind of hard to understand this stuff. And ultimately, the hope is that we'll keep on learning more about this. And I'm biased because I come from a postmortem background. I think the more, and what you hear, like I was at the last translational neuroscience focus meeting at biological psychiatry, I think the more we have access to brain tissue and have an idea of what happens in a very privileged, protected organ, the brain, that we can't biopsy in humans. I think the closer we get to getting a cleaner sense of where the illness comes from or where this difference comes from and how it expresses, and it'll make it much easier to incorporate all these new techniques we have about what's going on and how to use it effectively to help us help patients get better.
Cheryl, would you like to add anything to that?
I'm not sure I can add anything to that, but certainly to translate, what Dr. K is talking about is like when we have that understanding, it will help us as therapists as well. So it helps us understand better when to intervene, how to intervene, how to use medication. Oftentimes medication used in someone that without neurodiversity, it doesn't, it works differently. So just having that understanding of those brain differences so we know how to tailor interventions. And particularly, as Dr. K said, is when those windows, those neuroplasticity windows open where we have the punch, it packs the most punch. Like we need to get in and be able to do it then, because otherwise it's more rehabilitative oftentimes. So, understanding when and how is something, yes, the more we know, the better we can do and more we can help.
And I think this interchange is a good example of why it's very useful for me to work with Cheryl. So there's obviously, benefit in sometimes hearing something from someone who has a slightly higher skill set with communication.
The final question I have for both of you, who are the dream team, you work great together. What do you wish all your fellow mental health providers understood about autism? What's one thing you wish they all understood?
There's so many things, and that's very difficult to answer. We both, Dr. K and I both see a lot of people that have been through a lot of therapists and a lot of doctors. And I guess if there was one thing, I wish that everybody had a little more up-to-date information, psychoeducation on autism and how that, mental health conditions express differently, how medications may work differently, how you can't, expect to use something with someone neurodivergent and get the same result as someone neurotypical. I mean, sometimes you can, but oftentimes not. So I think it's first to do no harm, like to have that information so we're not making matters worse, because we see a lot of people come to us and they're worse as a result. So that would be my answer.
Mine, in agreement with what you're saying, and I applaud that view, is every year for about 35 years I go up to Boston University to give the first year medical students their anatomy lecture, an upper extremity anatomy, and my alma mater. But I also get to talk to them a little bit about being a doctor. And I was amazed that in the whole medical school curriculum, in speaking to the leaders there's nothing about neurodiversity. I'm going back several years, and so I gave the first ever lecture in neurodiversity, just as a concept. And I gave it to the first year medical students so they could kind of plant a seed going forward. And now, not because of me, but, all over, neurodiversity is being included and is now recognized and everything. But I share your frustrations that everybody's not up on it. The average family physician is first now getting exposed to this stuff. And they're many times the first line of defense, as are nurse practitioners.
So I very much agree as a 1-alpha what Cheryl said about the fact that the first thing would be like a rising tide lifts all boats to increase the amount of education. And I agree that would be the 1-alpha. And then is like a number 2, since I let you do all the work with the heavy lifting, Cheryl, of to answering the initial question, would be I do think, from my perspective, in terms of what I've seen over time, I do think that oftentimes when you look at interventions and people are plugged in, like we all have our skill sets and we all have our roles in the treatment and diagnostic ecosystem in autism. I think that sometimes there can be a little bit of focus on what the limitations are in a given individual. And then like Cheryl's eye head, and obviously this is something Cheryl and I do all the time. This is what Cheryl would have said as the one Bravo. But it becomes really, really important to understand how critical it is to convey that the neural circuitry in autism conveys vulnerability. It also conveys strengths, and that identification and recognition of those strengths and taking advantage of those strengths during peak cortical plasticity windows during adolescence, and learning how to take advantage of granular data retention and pattern generation and the like, and figuring out what kind of data you're best at playing with, that changes outcome. That changes long-term outcome, and it gives opportunity. So Cheryl and I have had multiple presentations where we're just not able to move the needle and an individual is in a difficult place. And what ends up shifting the narrative a lot is they're finally getting a chance to exercise what they're strong at, like BH. We were just talking about Cheryl like a day or two ago, and she can mention about it, but just having the opportunity to focus on strengths as opposed to vulnerabilities in terms of what you can do makes a massive difference in outcome. And I do think if you're a little bit less experienced in the field, you're doing your job and you want to put out the fire and you're focused on putting out the fire. But sometimes it's easy then to lose sight of like this mountain you could scale, where if you get it, it just gives you much more power and vision.
Great stuff. Absolutely. Harnessing the strengths, a strength-based model as opposed to a weakness-based model. Dr. Stephen Shore, in his book, he's a big proponent of that as well. And you bring up an excellent point, because it's in everything we do that we're focusing on what you can't do instead of what you can do, and can do very well in many cases. Well, Cheryl Checkers and Dr. Christopher Kay, both of you are doing a marvelous job specializing in the overlap of autism and mental health issues. Thank you so much for sharing your knowledge with us. We look forward to working with you in the future, and keep up the great work. Thank you very much.
Thank you so much, Dr. Reitman.
Thank you very much for the chance to do this, and thank you for the work that you do.
Exploring Different Brains is a production of Different Brains. Visit us at differentbrains.org.